All right, guys, let's talk ventilator modes. So I want to make this a series and kind of talk about the different modes that we put patients on while they're in surgery and how we use these modes to breathe for the patient. And a lot of these are seen in the ICU that are managed by the intensivist, anesthesiologist, or a pulmonologist. But in surgery, the anesthesia provider, whoever that is, whether it's the CRNA, the anesthesiologist, or the anesthesiologist assistant, is the one running the anesthesia machine and the ventilator, which is breathing for the patient. So first of all, let's talk about the most common mode. Now, this is an older anesthesia machine. Volume control is essentially how much flow we are giving to the patient. And volume control is typically indicated in patients who have healthy lungs and don't have changes in compliance of the lungs and resistance of the airways. So for example, in the patient with COPD, they have really compliant but poorly elastic lungs, and what this means is it takes more pressure to inflate those lungs, but they're really compliant because the alveoli are tented open and they have what's called autopeep, or air trapping of the lungs. So in someone with COPD, you can use volume control, but you just want to be really careful because you have those changes in pressure and you can lead to barotrauma. So like I mentioned, volume control is how much we're giving the patient. So on the ventilator, we set a certain tidal volume that we want the patient to receive. And since the volume is set and it's constant, this means that the pressure is going to fluctuate and change in order to give that set volume that we program for the patient to receive. So this would make sense why it's normally used in people with healthy lungs, because if we have a lot of change in pressure, or if we have really high peak airway pressures in a patient's lungs who can't tolerate that, then this would put them at risk for barotrauma. So in volume control, the ventilator is going to terminate the breath when one of two things happens. The volume is either achieved and the patient gets the full tidal volume breath, or when the pressure exceeds a set limit that we program the ventilator to. So for example, if we set our Pmax, or our peak inspiratory pressure, to alarm or terminate the breath at 30 centimeters of water, like I'm showing you here, and you can see when I squeeze this bag that the pressure shoots up and you have that really sharp upstroke in that waveform. You can see that our tidal volumes are programmed for 300, but we are not reaching anywhere close to that. And that's because this pressure in the circuit is exceeding 30 centimeters of water and it's terminating that breath. Therefore, the patient is not getting that volume and it puts them at risk for atelectasis and collapsing of the smaller airways. And this is why people who have poorly compliant lungs or stiff and rigid lungs, these high changes in pressure can cause injury. So you want to make sure when you're setting your peak airway pressure, or your Pmax, you don't want to set it too low so that the ventilator can achieve that tidal volume breath that you program and you're not putting your patient at risk for atelectasis. That's volume control in a nutshell. So to summarize, volume control is how much we're giving the patient, usually given in healthy people with healthy lungs, can lead to atelectasis if the tidal volume is not achieved and the pressure in the circuit exceeds what you program. And be sure that when you set your Pmax, you don't set it too low so that the ventilator does not